You can tell I'm only a simple pediatrician, and I'm going to give you my spin on what I think works in the clinical setting. I agree with the previous speakers about the hormonal milieu that creates this always hungry syndrome that I see in kids associated with insulin resistance particularly. We're fortunate at the Nepean Hospital, where I joined in the end of April. I was working at the Children's Hospital in Brisbane prior to that, to have a publicly funded, and I believe this is true, the nation's, Australia's first whole of lifespan service, where we have a pediatric clinic, we have an adult clinic, we just got funding for a bariatric service for extreme obese adult patients. Dr. Waffa's in the audience. She's an obstetrician that looks after the pregnancy clinic. Kath Williams, who's not here, but Annette McDonald, the nursing coordinator, is here, looks after a preconception clinic. So that allows us to integrate care of in a family setting. It's fairly family-centric, very family-orientated. So if an adult parent obviously comes with their child with concerns about obesity to see me, and they fulfill the criteria based on BMI and other criteria related to comorbidity, they will be strongly encouraged to also join the service. So we have a multiple approach and a great team, as I'll outline. Now, Australia, as you could remember from this recent article in Nature Reviews Diseases, is equivalent to North America in terms of the average BMI. You can see here the colours here between the two continents, and that doesn't escape the children of these parents, of these adults, obviously. And this recent paper published in New England looked at, again, American data, but alarming increase in type 2 diabetes in adult and youth. While type 1 is definitely increasing as well, there's a much, much greater increase in type 2, driven by the obesity epidemic in the States. We're not seeing that quite here yet in Australia, but in certain ethnic groups, South Pacific Islanders, Asian, Indian, Fijian Indians like that, we are seeing more and more type 2s as young as 10 years of age in my clinic, which is alarming. And the trend from the latest data suggests that the overall prevalence rates of obesity are plateauing in children around about 25% in Australia. The actual severity or degree of obesity and waist circumference reflecting central obesity is increasing. So I'm seeing routinely 10-year-olds who I call them my 10X kids. They're 100 kilograms, 13, 140, 150 kilograms. That's a pretty routine patient I see in Western Sydney, which is, as I'll show you, I might skip that slide, is at the heart of the obesity epidemic. Now, for today, I just wanted to throw these ideas out to you. I may or may not talk specifically about them, but you can ask me. But I'd like to think about food and the relationship with mood, because I see it in my patients in terms of attention deficit hyperactivity disorder, autism. These kids have very, very altered food sensation and preferences, and the mood affects their food preference, but their food also affects their mood and behavior, and leads to emotional overeating, which is very hard for parents to control. So they often lose resilience and then feed into this poor nutrition, which then aggravates their weight gain, basically. I put there looking for love. I mean, food is an emotional thing, and in different cultures, it's an expression of love from the parent to the child. And I see that often, not just from the parent, but the grandparent, who sabotages what the mother usually is trying to do to help the child. I also see a huge amount of mindless eating, which feeds into this always hungry, what I call always hungry syndrome, which is partly driven by insulin suppression of leptin centrally, but is also due to very fast eating processed food, rich fat, high sugar, calories, etc. And then the fast versus the slow food movement, if you believe in that. There's also a complete distortion about what's normal calorific intake. When I was growing up, we got a certain size plate, we got a certain size portion on our plate with half of it full with vegetables, small amount of meat, etc. Dessert was a treat, usually on the weekend. And more often than not, my parents would say, just go to the park and play, etc. And they wouldn't worry about you when you didn't come back for a few hours. But that sort of distortion about safety, distortion about calories, about what's a normal plate size for a 5-year-old, 7-year-old, 10-year-old, partly driven by media and partly driven by advertising, I think, and the busy lifestyle that we all have. You know, the two-parent job, lack of time, apparent lack of time to shop healthily, cook healthily, etc. There's also this inactivity distortion with screen time, games, screen addiction, etc., which I see a lot in the adolescents who do the internet gaming, etc. And that also feeds into their mood, sleep deprivation, hunger, etc., etc. So a whole of family approach is obviously best. It's got to be parent-led. Sometimes I think, oh God, this child, wouldn't it be good to do a parent transplant on this family? Which has happened in some cases where we've had to get family services, or what we call child safety services, involved, because the parents have, for whatever reason, usually related to drug and alcohol, are neglecting the children, not by underfeeding them, but by overfeeding them and not providing them nurturing environment, love in a nurturing way and as stress-free as one can in childhood. I don't believe in a stress-free childhood. I think children should have normal degrees of stress to build resilience, but when you're in that sort of chronic stress situation where there's drugs, there's alcohol, there's domestic violence, there's all those pointers to social disintegration, then that spills over to these children developing obesity as part of the symptom of that social disintegration. Now, I've started on a very pessimistic note, but being a pediatrician, I always try to be optimistic, because that's the reason I gave up wanting to do geriatrics. I didn't want to look after people who smoke or drank or didn't exercise. I thought that children at least have a chance to, as a pediatrician, to help them achieve their full potential, and I still believe that. Now, this is the standard diet, exercise, and behaviour therapy mainstay of weight management, you could say, in adults and children, and as Carell and the others have said, that, because of the hormonal drivers to re-eat, hunger, etc., it's usually not successful. Now, where I work in Western Sydney, the other impact is of just the urban sprawl and the urban environment, where lack of access to public transport, longer car journeys for parents to school and to work, and lower socioeconomic class and education levels all contribute to increased, at least twice prevalent rates of obesity, diabetes, and heart disease. So for those of you not from Sydney, right here in the Blue Mountains in the yellow on your left of your slide, beautiful Blue Mountains, World Heritage Site. In the valley where I work down below in Penrith, that's where the clinic's located, and this is the highest rates of diabetes in that Penrith Hawkesbury region in the western. On the far right is the beautiful Sydney Harbour, surrounded by the rich northern suburbs. I also live on the eastern suburbs near the beach, which has lots of accessibility to parks, public transport, etc. But if you're living out at Penrith and you have to travel 2 or 3 hours a week, it's difficult, you can imagine, which I do travel 2 hours to get to work sometimes, to find the time to exercise, to shop, cook healthily, etc. These are the obesity and cardiovascular attributable deaths in those areas as well, huge. So within the family obesity service, as I said, it's the nation's first whole of lifespan multidisciplinary clinic. We're linked with the Charles Perkins, so research is certainly a major agenda of the clinic service, which we're beginning with various collaborators. And as I say, we just got funding for a bariatric service for adults, and I'm hoping that we can expand that to adolescents with type 2 diabetes eventually. And we've got an amazing team. I'm very privileged to work with this group of team. I'm the token male in the team, but that's fine, I don't mind that. Annette's here and Kath's here at the meeting, but not here at this. And we use the big C, compassion. We have a team that I think are very motivated. That's probably because we've only been working together for 6 months, and we'll see if it's the same in 6 years or 1 year. But it's very patient and family-centric. We have a wonderful clinic. It looks like this. There's no patients in it there, obviously. It's usually full, but there are chairs which patients don't feel embarrassed to sit in, bariatric beds, etc. And when the kids come, we get toys out. We get 10-pin bowling kits, etc. to get them involved in moving and enjoying the clinic environment. Now, we all know it's a family problem, and obviously prevention is better than cure. So if you look at children who are obese as pre-pubertal age, 25% of them will be obese adults, but by the time you get to adolescence, those hormonal milieus that are set in the hypothalamus are pretty much going to keep them there as obese adults. About 75% of them will remain obese as adults if they're obese as adolescents. So hence the pregnancy clinic and the early conception clinic to really think about preventing all those epigenetic effects of overweight at the time of pregnancy or during pregnancy on fetal growth and fetal set point for appetite and body mass and fat mass. And as I said, we accept co-referrals from within the family. So if the child comes with a parent who's obese who fulfills the criteria, we encourage the parent to participate in the program. I mentioned about ADHD and autism and obesity. I see about 25% of my clinic is patients with autism or obesity associated with autism or ADHD, or what we call, the DSM calls oppositional defiance disorder. It's quite amazing, ODD, odd. I hate that term, but these are kids who don't listen to their parents for whatever reason. They will not do exercise, they will not eat healthy options if given, etc. But that's partly because of their brain, which I agree. I put up my hand when I said the brain is the most important part of the organ that controls your risk. And obviously the reasons for child obesity are complex. I believe it's a part of a dysbiotic life, if you like to use that term, where there's prenatal effects, early infant effects, lack of breastfeeding, nutritional feeding programming, gut microbe, antibiotic effects, and that air pollution has even been implicated. Nature deficit disorder, kids don't go out anymore and enjoy sunrise or walks or things. So that in itself, being outdoors, getting vitamin D, the resilience of being physically active and pushing yourself in challenges, and with that, creating a tired child who will sleep all night and not be up watching the screen, etc. So this is a typical chart I see in my clinic, except the problem is I see them when they're about 13 or 14, but often I look back at the charts and you can document when they actually became obese, but nothing was ever done, or they might have seen a dietitian who said you've got to eat less and exercise more. I'm sure dietitians are more sophisticated now and they understand the emotional involvement in the whole process. So obviously, if an intervention can occur in pre-pubertal periods, you're going to have more effect. And that's the BMI. There are now BMI charts which are used here in the UK, which we use in the clinic, which cope with extreme obesity patients. So you can get these online from the Royal College of Paediatrics and Child Health. You might have gone to the breakfast meeting from the Ministry of Health from New South Wales this morning. They've put out some really great resources. I'd encourage you to look at it. They're freely downloadable at the Healthy Kids website under this campaigns and programs, where they've got this assess, advise, assist and arrange program at prohealthykids.newsouthwales.gov.au. They have a flowchart for weight assessment, which is aimed at primary health care, and they have links, at least in Sydney, to our clinic, the Westmead Children's Hospital Clinic, North Shore, etc., and another series of burgeoning multidisciplinary clinics that's happening around the state in New South Wales. So things are happening in New South Wales. One reason I left Queensland was nothing was happening up there. And Louise Bauer and Shirley Alexander's Wait for Kids program here, which is worth doing and gives you insight as a general practitioner into how to approach families to bring up the elephant in the room discussion about the child who is obviously obese, comes for asthma or immunisation, etc. And the resources here within that are well worth utilising. So some basic tenets of a healthy family. It's interesting, we study obese families, but I think it's just as important. I don't know as much data has been to study families who are healthy and are actually able to stay in a healthy weight range and healthy physical activity, physical range, etc. So obviously parents as role models, one rule for all for one. I believe in this division of responsibility in feeding and physical activity from the Ellen Satter Institute in the States is very good, and I try to encourage parents to implement Ellen Satter's principles there. Triple P, positive parenting-based programs, have got a lot of world-based evidence, and obviously decreasing energy intake, increasing energy expenditure as a family, focusing on mindful eating, slow eating, eating together as a family, all those things, being active together as a family are important. That's Ellen Satter website. So getting back to, Michael Lunig's my favourite philosopher, but getting back to understanding that, focusing on mindful eating. Susan Albers from the Cleveland Clinic is excellent. She's got a huge number of resources that you can access, which are very useful for the families, which I use in the clinic. And just asking these simple questions: are you actually eating real food? Is the food that you're eating recognisable by your grandmother, or I should say your great-grandmother, maybe? And obviously we know diets don't work in the long term. This is a very evidence-based book and based from Professor David Ludwig at Boston Children's Hospital, and a role for insulin, which drives hunger centrally through suppression of leptin. And I think his program is very effective. Talks about using healthy fats, low GI, low carbs, reducing carbs in general. I'll skip that slide, and then this is just talking about insulin. So I think prevention is the key. We need to use the same approach that the smoking campaign used in public health to coordinate at multiple levels of public health to prevent this, because obviously it's easy, to develop all these new drugs that we're developing to treat severely obese patients, but we've still got to prevent all these new generation of children and adolescents who are coming through to stay healthier, be more active, and prevent them from getting obesity and type 2 diabetes. And then finally, I'll just say what works: whole of family, parent lifestyle-led lifestyle changes, good data about cognitive behavior therapy in adolescents, and mindful-based therapies, obviously a healthy nutrition and active lifestyle, increasing evidence about the role of aerobic training, especially resistance training, to focus on not just weight loss, obviously, but physical fitness, improving family physical fitness. There's not much in the armory for pediatrics in terms of pharmacotherapy, but with the drugs for adolescents, GLP-1, there are some trials coming out with that may show some promise. And then there's this increasing evidence about bariatric surgery, which John might talk about in adolescents with severe obesity, especially those with type 2 diabetes. I might finish there as I'm run out of time, and if there's any questions later, I'll be happy to answer them. Thank you.